My name is Oretta Tupola. I'm one of CHWs with AHEC. We started this CHW group with the School of Medicine and have been doing presentations like this to share with our students just some of the things that we experience in our communities and some of the best practices that we use to work with our diverse communities here in Utah. I am with AHEC now as a staff, but also am a chief administrative officer for a community-based organization. And then also along with all of these other CHWs, we organize the Utah Community Health Worker Association that is here in the state. Glad to be here.
Cool. Let's have Jeanette go next.
Okay, thank you. My name is Jeanette Villalba. I work as a community health coordinator at Vamos Health Clinic, and I'm part of the IHEC program as well. And I work with the Hispanic Latino community in this area.
Cool. Thank you, Jeanette. And then we'll go to Kathy. Wait, I saw your camera go on, so I'll have you go next.
Thank you. Kathy Wolfsfeld here. I represent the African American community, and I work out of the Calvary Baptist Church in downtown Salt Lake City. And happy to be here talking about such an important topic. Thank you.
Cool. Thank you, Kathy. And then we'll go to Valentine.
Hi, my name is Valentine Mukundene. I am one of the community health workers with AHEC, and I work with the African immigrants, especially refugees. I'm so happy to be with you. Thank you.
Cool. Thank you, everybody, for introducing themselves. I'll introduce myself and then I'll hand it back over to Retta. My name is Ivana Holiday. I am from the Dene tribe, so Navajo tribe from the Navajo Nation. I am one of the community health workers, help with working with Native American Indigenous peoples here in Salt Lake City, but I also work at Utah Transit Authority too, so UTA, the buses and trains.
Thank you, Ivana, and thank you everyone for introducing yourselves. So again, welcome everyone. Today's topic is social determinants of health, the diabetes story. And all of us are going to share some of our experiences in working with diabetes in the state. And so our objectives for today is to share some statewide data, just a little bit, because we want you to also get familiar with the different places in Utah or about Utah data. And visiting those websites that the State Department has, also CDC and the IRIS website also has some data, but we really want to focus today on how diabetes shows up in our communities, how that has impacted us, and then the advocacy and policy work that we have all been involved in to address these disparities in our different communities, especially in our underserved and rural communities. Now we'll talk about what social determinants of health are and what they look like, describe our roles in that, and then also just talk about some models of care. And we would love for you to all be a part of this discussion. If you have questions, please just unmute yourself and share. Or if you have a comment about something that we are saying or a question, please feel free to unmute and share, or you can use the raise the hand button and we will get to you and answer those questions. We really want this presentation to be a dialogue with you, because we want you to get out of it what you came here for, and to answer any of the questions that you might have. And then we'll talk a little bit through the presentation about One Health Collaborative, which is the collaborative that the governor put together to address a lot of the barriers in health systems, and how we can work together as a community and also as a state and with the systems to improve our delivery of care. Next slide, Rana. So I just put this as this is from the Department of Health's website on health disparities, just showing what the prevalence is in Utah, how many undiagnosed cases are, pre-diabetes, and I know like the CHWs will share some stories about pre-diabetes, diabetes management, and the difference and what available resources are out here. and then new diagnoses. So 16,000 adults diagnosed with diabetes. If you go to the Health Equity Office's website, there are reports specific to specific communities in Utah with diabetes rates. And what surprises me about that report is the report on Native Hawaiians and Pacific Islanders is for the first time this past report, diabetes was not on there as a disparity. I know that in the state, as we work on diabetes, our numbers are good when you look at the whole state and diabetes. But if you look at our specific communities, there are very high rates and the prevalence is high as well. And the numbers sometimes, I'm not trying to say, anything negative about data, but we've been added to these conversations about how data is collected, who the data is collected with, and where, because for me, being on the ground and then looking at the reports and even attending the community data assessments for IHC, for the U, the numbers are not matching what I'm seeing in community. And so that's why we are part of these discussions to ask them, where are you or how are you collecting this data? Because every day we are helping community members with their diabetes, but it is unmanaged because they're not reporting it. They're not going to the doctor. They don't have a primary care provider. And so there's so many things and barriers for the reasons why the numbers are not matching what we're seeing on the ground. Anyone else want to share anything around data? Or what you've seen in the state? Are you seeing the same things that I'm sharing in the Pacific Island community in your communities?
Yeah, and well, this is Jeanette with the Hispanic community. Our numbers is like 14.4% of the population. They are saying that they are diagnosed with diabetes or pre-diabetes. And I think, like you were saying, the numbers can give you overview, but the real numbers probably are not like that, because many people, they don't want to go to take a test because they don't want to know, and probably the numbers are higher than the ones that is showing. And because of the stigma, the shame, they don't want to do the test, because if they know what are they going to do. And yeah, the data and the numbers are good, but probably in all our communities are higher than what they show. Mm-hmm.
I agree with Jeanette. The numbers in Utah for the African American community is at 13%, and which is really high because we are under 1% of the population. And, my community it's like a foregone conclusion that they will get diabetes. It's not if, but when. And so, people are nervous. They have family members that have uncontrolled diabetes with the consequences that go along with it. And so they're less likely to get tested themselves because they don't want the same outcome. And so they think that, denial is a good treatment option.
Ivana or Valentin, you have anything on data you want to share?
Well, I agree with what everybody have said. What I can add is just that when we look at the numbers when we are talking about underrepresented communities, most of the times the real number is higher than what we are seeing, because many people, for example, in our refugee communities, do not participate in data collection or because of different reasons. It could be the way data was collected, what methods. were they understanding the language that was used? So I believe that, yeah, the numbers are always mostly higher than what we see.
If does anyone have any questions? If not, we can go to the next slide. Here's just another snapshot of data and the prevalence of the data. Just again, this was from looking at different sources. And for national DPP, which is the program that is most used here in the state, or is actually promoted or encouraged for our community, even our CBOs to use the National Diabetes Program. We have a lot to share about the National Diabetes Program, as we all have been facilitators of that program. And the NDPP is for diabetes prevention and management, but there is another curriculum for before you get to that phase, like how do we do education about diabetes with our communities. And one of the barriers of the NDPP program has been the very strict guidelines around fidelity that we have to keep because it's a evidence-based practice. And what's hard about that in working in our communities is that we have to be flexible with community members. So reading from a slide or just following a script with our community members is pretty much a no-go, because they will either fall asleep or they won't come back. Or the material that's used there is for general households, whereas if I say, if you go, or when you change your diet, I want your plate to look like this My Plate. And we use the Western My Plate that is often used in this as an example in this program. It doesn't look like the plate that our households are eating. And so I can't understand how to change my diet based off the information that I'm getting, because it's nothing like the plate that I have in my own household. So just back in Hawaii, when we were using, I think it was CDS&P, which was the Chronic Disease and Self-Management for Health, Chronic Disease Management, we decided not to go with that curriculum and tailored a curriculum to our community by developing our own plate. And we would tell people, I want you to go home and make a list of the things that you have in your household. And then we help them to sort, what does the portion of greens look like? What does the portion of protein look like? And help them to manage in that way. And even when we start having discussions around exercise, we'll talk about things that they can do in their house, like lift milk bottles instead of go to the gym and lift weights, or walk around their living room a couple of times while they're watching their favorite show. Just doing different things like that are relevant to their lifestyle and the cost of their living, so that it's more effective. And anyone else want to add to that?
Well, I'm glad you are bringing up that, Oretta, because when we talk about like exercise or physical activities, I think it's important to make sure we tier it in a way that makes sense to our communities. Because, for example, in my refugee community, going to the gym, paying the gym membership is not a typical thing. However, most of them work in these manufacturing jobs where they are physically active for 8 hours. So, or they take a walk outside, or they do other physical work that require them to be physically active. So I think it's really important that when we talk about exercise, like the word exercise might not mean a lot. So we have to make sure we define it according to our lifestyle.
Yeah, for us, it happened exactly like Oretta was saying about the programs. First is the length of the program, like it's too long, and we have to adapt it to our communities as well, and trying to make it work for them because of the busy schedule. We have to create kind of our own based on the information that they provide. We adapt it and we do it like more personalized, like one-on-one. Sometimes we have groups, but it's not all the time because of the schedule of the people, the community members. And we have to do it like one-on-one, do this education. And it could be challenging sometimes because, the foods that they provide in the program is not cultural appropriate. Many people in our community, they don't have like canned foods, and we have to adapt our foods to work for them. Like Goreta was saying, they bring their own food, and then we trying to explain the portions, the calories, and what is the best option for this kind of food. And yeah, we have to adapt it our own to provide that information that is so important for the community members. Mhm.
We at Calvary run a diabetes prevention program for the community. And during that, we have a chef that will tailor the food that we normally eat and make it diabetic appropriate. And so all of the high carb, high salt, high sugar foods that we traditionally have grown up on with the sauces and all of that, they learn how to eat the same food but doing it healthy so that their diabetes, their numbers won't spike after they eat it and things like that. So that's how we are um, rolling with the diabetes prevention program at Calvary.
Yeah, and I think the same thing within like the Native community at the Urban Indian Center, they do offer they call it I think it's Circle of Health program for diabetes prevention or diabetes management. They work with one of the dietitians on how to plan out. They do it usually after hours too. So when people are off work, they work. So they work with a lot of the patients and clients that they see within the program. So tailoring, after hour availabilities for programs like that. And then they do provide like food kits for them to try out different foods. And same thing, they have that diabetes education and how to manage it. And they go through different phases each week too. So it's like a few weeks process and then another continuation after that. So there are like programs that are tailoring it a little bit more towards Native people or Indigenous people too.
Okay, next slide. Ron. So this is just the trends and the burden here in Utah. And like all of us have said, overall Utah looks pretty good, but there's still a lot of our patients and communities who are dealing with the unmanagement of their diabetes, uncontrolled management of their diabetes. And so we have been working really hard on the ground to provide these more culturally tailored best practices within our different communities, but also have been working a lot with the schools to try to better educate or share our resources. Share our resources with providers, with the students in the School of Medicine or in the health professions, so that we can better address this together. Well, community health workers are not providers, we are not doctors. And we understand that we do get trained in diabetes management and education through the programs, and that's how we are able to take the cultural pieces and the lived experience and then merge that with the training that we get from these specific curriculums. Like it says here, it looks like there is a slight decline in diabetes, and that we're doing better in numbers. But for us, sometimes again, the everyday patient that we see, a lot of times they're showing up in the emergency room. Their numbers are their A1Cs are high, or they're there for other chronic diseases that are triggered and they all it's so complex that we have to deal with one thing at a time. And that is the reason why we want to have this conversation with you all about social determinants of health and how important addressing those SDOH barriers, because before they will even be able to take in all this information about following their prescription, going to the doctors, testing their sugar. They want to make sure that they have their basic necessities met, basic needs met, housing, transportation, a lot of those things, money, financial means. All of those things are very important in their health. Next slide. Okay, so these are some of the things that I just mentioned. And so I want all of the CHWs to just share some of this SDOH barriers that you are seeing in your community, how that impacts your community, but also what resources you are providing to address this. How are we working together to address SDOH in our community? Some of them are listed here and you guys will get the slides.
One of the areas, and like in terms of like environment or neighborhood where our community live, because these are the people who are with low income, so they are limited. Their income limits them to what kind of a home they can live in. They are mostly looking for cheap housing, and sometimes those neighborhoods might not have enough accommodation in terms of like having like public parks where the kids can go to play, or sidewalks, all these things that you might need that can facilitate them to stay physically active or to take a walk after when they have time. Also, in terms of the health literacy, I mean, most of the education documents that they were supposed to use are written in English, and English is not our first language. We have to learn 5 languages before we can get to English. So all these are some of the social determinant of health that limits our health, wellness, and leads to all these health issues.
I will add to what Valentine was saying about depend on the neighborhood. Sometimes they don't have access to community gardens, to farm markets, and it's hard for them to sometimes to get the healthy food. You know, when you go to the store and you see the organic foods, how expensive it is, and that turning up in a barrier for people to get access to a healthy food if they don't have the information. You know, that's why it's important for a coach or a community helper sit down with them and see what are the options, what they can use. But what is happening as well is because diabetes, sometimes they don't show any symptoms like right away. People, when they receive the diagnosis, they feel like it's not that urgent, that I don't feel anything yet. It's not that urgent, I can wait. And they delay the treatment, delay the information because they don't feel it. And that leads to a complication like we were seeing before, you know, all the complications that diabetes can show after in life if we don't take care of that. And the social determinants of health definitely is, sometimes they show us how they manage the way they treat their own health, because sometimes they don't have, for example, money to pay for the medicine. Sometimes when they receive the prescription, they receive the prescription for medicine for 3 months. And sometimes they don't have money to pay for the 3 months. And sometimes we have to advocate for them with the providers that can you provide at least like once and two more refills because they don't have enough money to get all the 3 months in advance. And that can turn in a barrier. And another barrier, not just systematics and access to help, but as well the personal barriers, the what you're thinking about, your perception about diabetes, it brings the stigma, the shame. They don't want to share this with the family members because what they're going to think about it. And they don't want to talk about this personal thing with their own partners at home. They want to avoid this conversation because for so many people this bring like, oh, I'm going to die, I'm going to lose limbs, and what is going to happen to me. So much things when they receive this notification that they are pre-diabetes or diabetes is like a shock to them. And that's why it's so important to guide them in their journey to go through this diabetes or pre-diabetes.
And the inadequate access to healthcare. A lot of people don't have a primary care physician, and so they're not on a regular maintenance, testing and prevention program. And so when they finally do get to go to the doctor, their numbers are really high. They're in, that's when their health it's an emergency, you know, because they've had to wait so long because they don't have access to regular health care. Um, that could be having something to do with the poverty rate, lack of insurance. Um, and we're talking about the food. There are food deserts where there's only convenience stores. You don't have a grocery store where you have access to fresh fruits and vegetables, but your only access is at a convenience store. And we've all been there. We know what's in a convenience store. We have our junk food, we have our chips and our high starch bread sandwiches and things like that. Those are their options. And so it's not asking, um, why do I have diabetes, but why don't I? Because everything seems to be against you if you're living in a rural community, if you don't have healthcare access, you don't have a primary, you don't have health insurance, or the health insurance is really not great and you can't get access because you still have to pay out of pocket and you don't have money out of pocket. It's a vicious cycle.
I would
And
like to add to Kathy, sorry, about the fragmented care. When they go to community health fairs, or they receive some help here, some help there, but at the end there is not a continued care, and that contribute to complications as well.
yeah, within like the Native community, like Kathy was saying, a lot of like food deserts. So my experience is very unique because I grew up like on the reservation and I've seen a lot of like food deserts. On the Navajo Nation, there's only 13 grocery stores within the whole Navajo Nation, and they kind of compare the size to, I think, West Virginia or Virginia. So it's pretty big and vast. So there's only 13 there. So that kind of contributes to a lot of the access to healthy options. And I think some of that comes down to like some historical context to a lot of members of the community who do have diabetes or are pre-diabetic. They I think it's kind of that's what they're used to, is like surviving off of like canned food, unhealthy foods. During those times there's a lot of job insecurities and some of that overlaps now too. There's not a lot of like good paying jobs on the reservation. Sometimes you need to have a degree and a certain amount of years of experience to be able to work in those high paying jobs. And then for like healthcare access, like in the urban setting, here in Salt Lake, there's some barriers to that. So the Urban Indian Center has two clinic. They have a clinic in Murray, and then they also have like our community center by Ballpark Station. But the Murray Clinic, before they actually like started their services there was a bus stop located in front of the clinic. And then once they were establishing their services, the bus stop was no longer in service. So even just a barrier to that in itself, that's just one example of how transportation can limit those different areas. And I think like health literacy too is another aspects because a lot of community members, and I can speak for like my own personal experience with my family too. They don't really understand like some management terms or the terms used. And then some of the devices that they give them too, they take it home, but the connection to what they're talking about in clinic or when they're during their office visits or the doctor's visits, sometimes they go home and it's a little bit harder for them to connect that. And uh my my parents, they grew up speaking Navajo, so that's their primary language. And kind of what Valentine was talking about, there's different layers to language barrier, and that goes back to health literacy too. So that's a little bit about my insight.
Just wondering if any of the scholars have any questions, or have any of you participated in the community survey with the School of Medicine, some community health workers? If you have, can you do a thumbs up emoji? Doesn't look like. Okay. I just share that because as we were talking about access and the neighborhoods and the environment and economic stability, we one of the assignments for some of the students in the School of Medicine was to do a community survey. And I forgot what the original survey was called. It's an evidence-based survey they use to assess communities and determine all of these things like poverty and access and all of that. And we had suggested to them, why don't you take the students into these communities? And that started the activity where we are going with the students and walking through Salt Lake City, walking through Rose Park, walking through Glendale, and just seeing, having them observe instead of just look online and check off on a piece of paper, what these communities lack and don't, and what their strengths and what their weaknesses are. And the experience and the feedback that we have received from students of just walking around in these neighborhoods, they were like, oh my gosh, we went in that store and the food is, we said, okay, you have $10, go in the store and go buy you something to eat. I mean, students too also are not making a lot of money and we are racking up student debt. And so as the students were going in there, they're like walking out saying, we can't even afford anything in there for $10. You know, we could buy a drink or something. And so that was one of the observations. We walked through the not road home, but well, actually a lot of road home as well. And 4th Street Clinic, all of those things, we walked through those neighborhoods and through the clinic, went through the processes that patients have to go through. And just the feedback we got from them about, oh my gosh, that was so difficult. And why do they have to bring this and this and this to these appointments? And so just experiencing kind of firsthand what community members have to go through and how difficult that is, and how you could be well one day and the next day homeless and without a job. And what was interesting for me in that experience is I teach also at the UVU, the PA school, and the students there, until they were able to speak on their own experiences of having a lot of money and then coming from home with their family and their parents to now becoming a student and having to make their own money, go to school where they don't have insurance, or they got married in another state while they were at school and now not having insurance. did they find themselves in this place where they were struggling to get through the system, to access these basic necessities that for so long I took advantage of, at least having insurance under my mom. And so with the prevalence of diabetes and how high it is in our communities, we experiencing these burdens of social determinants. I mean, I hope that you can see as we're telling these stories how that can prevent someone from getting better, how their outcomes can come out as like non-compliant in the health records because they are not following their medical treatment or their care treatment plans. Anybody have any questions around that? And can we go to the next slide, Ivan?
Yeah, so we do have a question
Okay.
from Tati. It says, how do cultural beliefs and practices affect diabetes management?
Well, I can say something about that. For example, in our refugee community, and this is why the power of like the environment you grew up in, you spend time in, it really influence your your whole life, your future life. So we have people who have lived in refugee camps for so long, for 20, 30 years. And in that situation, they don't have enough food. Everything is limited. It's just going with the basic. And then they come to America and life is a little bit better, if I can say, that they can afford more food than previously. So we see that because people, when they get here from our community, they have the hunger of, wanting to get everything that they were not able to afford back home, including like these sweet drinks and sweet food. And then that's why we end up with a lot of, health issues, including diabetes in our community. What adds to that is that physical activities here, they are less. People are driving everywhere. People, they don't get enough physical activities. So that's how the environment, our past and our present environment affect our health.
I will say with the Hispanic community, probably because the food is something that you don't want to lose. You lose many things, your family, your friends, you left everybody back home. And the only thing that connect you with your roots is the food. And sometimes for us is the tortilla, the rice, the beans, the pan dulce for us, it's, the sweet bread. It's something so attached to us. And sometimes it is so hard to give up all those habits that we have, and we have to work on that. But that can turn in a barrier, to people to make those changes. The family gatherings, sometimes you feel the pressure for family members, to eat, to share food with us, because it's part of the connection. And that can be a barrier to follow your plan, your treatment. In the health beliefs in the Hispanic community, we believe like diabetes can develop for a susto, when you get scared of something. Oh my gosh, you scare me, like, oh, this can drive me to develop diabetes. But if I take care of myself and don't stress, and that I'm going to be fine. And that influence the way that people when they follow treatment, the faith, like, oh, if I have my faith is going to save me, God is going to save me because I trust him, and he is going to make me healthy again. I'm not going to take my meds because I know that God is going to help me. And that can turn in a barrier too. It could be a good support, but if depends on the perspective, it can turn in a big barrier, to the urgency of treatment can be affected by those beliefs. And the house remedies, a lot of people believe like there's some teas, like they have this um, benefit for sugar levels, and they believe in the teas and all the remedies that they usually do back home. And we can validate those, but we need to provide the new treatments, and make sure that they receive and they accept that, because it could be hard because of all these beliefs and um, cultural barriers that ourselves put on our own. Yeah.
I think that you will find us sharing a lot of things that might sound repetitive about our different communities and the barriers we face, but also the beliefs, cultural beliefs. I know for Pacific Islanders, very similar to what Jeanette shared, the religion piece that, oh, if that's God's will for me and I die because of whatever, like COVID, when that happened, if I die because of COVID, then that's God's will for me. I will just accept that. That's the similar belief that happens in our Pacific Island community. And then again, also the connection to food. I am a foodie through and through. So I love to eat wherever I am. That's what helps me also, I think, heal from a lot of things that I've been afraid of for so long. I'll speak to that for a lot of people that I know in our community, that food is a way that we're able to come and sit down and have a family meal and talk about the things that are conflict in our community. And when you understand that about communities and their culture, and then you see why it's so difficult for us to change our practice from eating those comfort foods to now these healthier foods, even though it might help us to live longer. We have talked about this a lot. You see that there's a gap somewhere, there's a disconnect. So instead of saying you're so unhealthy, don't be lazy, change your food or you're going to die, those kinds of things have not helped us to change the outcomes. But what has helped us to change that is working with providers and health professionals to say, let's look at this. Let's understand what your feelings are around the food. What is it? What's the most hardest thing for you to change in this so that we can change those numbers? And so like COVID, even in diabetes, we'll change the conversation around and say, what are the most important things in your life that motivate you to live and want to be around? And they'll say, my grandchildren, my family, I really like my job, it's my passion job or whatever. And we'll use those strengths to say, okay, if you continue to eat the way that you do, your nutrition, the way that you're eating now, it's not going to help you live longer to see your grandkids. It's not going to help you to continue to do the job that you love, which means going out into community and doing activities and events and walks and all of these things. And that has changed their perspective a lot, because they're like, wow, that's a lot to give up. I love these things. I want to see my grandchildren grow up. And so we use motivational interviewing as one of the skills we use to help our communities come to get to a point of change talk. And as soon as we recognize that motivation, we'll start from there and say, okay, you said you want to live to, how do we do that? What can we do? We laugh at this because many of us in the core skills training, there was an example they gave in a video about, how about if you try, instead of 5 tortillas every night, you eat 3 tortillas every night. And everybody laughs about it. But really, that's the kinds of changes that help our community to see, like, okay, it doesn't have to be that bad. I don't have to give up everything I know and love, but I do have to make some changes so that we can be better. I hope that answered that question about cultural practices, Tatiana. There's another question she asked. What advice would you give someone newly diagnosed with diabetes that already has a physical job, such as construction?
My advice has always been do something different. Your body gets used to the same old, you know. So if you're in construction doing the same old routine, um, then your body needs to do something different, whatever that looks like. If you're standing jackhammering, you know, you need to walk around, you need to stretch, you need to do things that are different that'll trigger your body into thinking differently, for lack of a better term.
It is hard because sometimes they work in construction with 2, 3 jobs, and still they need to do some exercise. Like Kathy was saying, validate what they are doing and maybe add something different. And I will emphasize a little bit more in what they are eating, uh, because they already are kind of active with all the construction work that they do. If they can add something like Miss Kathy was saying, add something different, like walk after you have your dinner, maybe 15 minutes. It doesn't have to be a long walk, but it's something different that they can add. I know that they said that they are tired already, but that could be something. But in my case, I try to emphasize a little bit more in the food because they are already doing something, and I don't want them to feel like I minimize what they are doing in the construction. Yeah, that's what we're doing.
And Francis said in the chat, also to patients that really don't have time to exercise, maybe they work 2 jobs. Yeah, we see that all the time. They work so much and they not enough time to exercise. But again, they're moving around. So where is it that we focus on, like Jeanette said, the nutrition piece, or maybe it's cost of medication, why their diabetes, they've now uh, they're not able to manage their diabetes. We want to look at where our patients are at or our clients are at, and then work with them to address those gaps of care.
Yeah, and I do want to add a little bit on that too. Everybody's kind of saying like focusing on the nutrition part, maybe uh like having smaller portions, or having snacks throughout the day. My my dad, he had called me one day and he was like, "Hey, I kind of had a little scare over the weekend at work." And my dad, he is a blue collar man. He is a foreman on a power plant and he's a welder, so he oversees different teams and has to make sure he's like aware of himself and aware of everybody's safety too. So he's up and climbing and welding in different like difficult spot where he puts like his body snugged against things. He's on his knees all the time. But one day he called me and he's like, I kind of had a scare. My chest was like hurting and I just couldn't make it through the day. And then I went home and I took like some ibuprofen and I felt okay. And then I tried to go to work again, but I didn't. So I called in and he's like, yes, I've been good, but I've been better. And then I was like, oh, and he's like, but I want to change the way I'm eating. And I was like, how are you eating? And he's like, just like 2 pork chops and like canned corn. And then I was like, it's funny to me because he's my dad and he's just like this muscular guy. He's very like macho, very like he's just the ideal of like masculinity. So I was just like, oh, yeah. I mean, at least you got some corn. So I try to like validate him, like, yeah, you got some corn, but you need to do more. Like, you need to have like protein, like if you need protein from eggs, but not just focus on meat, like, or even like white meat. So just finding those different areas that work for him and like giving suggestions and things like that. So I think it's a realization in those moments for like people who are close to us, but also people in the community who need, I guess, like those scary moments where it's a little bit difficult. And because he's my dad, he feels comfortable sharing that, but not a lot of people have that support system. And sometimes if clients or community members, patients are comfortable sharing that type of information, like, take it to heart. Because a lot of our community members, they have their own little silent struggles, and sometimes that moment where they feel like you're an ear to listen and they feel like a safe space with you, then handle that with care.
Thanks so much, Ivana. That's so important. And I think all of our communities, we share this a lot. Our community, the reason why we show up in the emergency most of the time is because we don't want to talk about the things that are, might be holding us back from living our most healthiest lives. And so we will go and go and go and go until, a heart attack, or till I get sick, or I have a fever and I can't do anything. And the motivation behind that is not because I feel sick. It's because if I am sick, I can't take care of my kids, or I can't take care of my husband or my parents. And so for someone to come to the doctors and say, I need help, I really want to change, something is wrong with me, I need help with whatever it is. Like she said, take it to heart. Know that they must trust you, because trust is a huge issue of why a lot of our community members, or vulnerable community members, won't share or won't go to the doctor to figure out what's going on. And also the masculinity piece that Ivana brings up is also huge. To go to someone and say that I don't go because I can't pay for the copay, or I don't have enough money to buy food or buy healthy food, or that there's a judgment, a silent judgment that a lot of even mothers feel about not being able to provide the most healthiest things for our children or for our families. And so these are just very difficult things to talk about. And so coming to the provider's office where you're telling a complete stranger, because we don't take advantage of the primary care we have sometimes. If I'll tell you, I'll just share this. In the beginning, when we were looking at Pacific Islanders and diabetes, we were like, what do we do first? Let's go find out who all has diabetes in our community and where they're going if they have diabetes, if they have insurance or not. We could not find one database that could tell us how many Pacific Islanders had insurance and where they were going for diabetes management. Because even though most of the Pacific Islanders that we surveyed said we have insurance, we're like, then why are you not going to the doctors if you have insurance? We found out a lot of these things through our assessments, just talking story with them and finding out how big of a barrier social determinants of health are. And so it's really key. And these next two slides, which I think you're hearing from us as we share our role as community health workers, as we're addressing diabetes in our communities, to be a bridge, a cultural bridge, to be more specific, but also not just for our community, but for systems, for providers, for help. That's why we love this opportunity to talk with you all, to build relationships with you all, because as you go through your learning and your practice, and then you become the professionals in the field, we built a relationship where you can say to us, hey, I have this patient, I don't know what to do with them, or I don't understand the English, their language. Can you find someone to help us? That's what we are here for, is to work in partnership with our systems to better provide access and education for our community members. And we are working on every level of the field, from government, from advocacy and policy, to universities teaching. We're in our schools, and then we're on the ground in community as a part of our community-based organizations and clinics, providing this kind of information. Next slide. And then I'll let you all share stuff, maybe one best practice that you feel has been, and let's try to share different ones that has been key in your working with your community. And I think it will answer one of Tatiana's questions of, are there agencies that help people obtain medications at low cost or free, even for a while? And have you found the group visits helpful for diabetes management? So maybe just share the best practices. I think it'll answer that question, because part of your work in dealing with diabetes is connecting our community to these resources so that they can afford it and so they have access to it.
In the community health clinics, they have they have vouchers and they have access to low cost medications. And that's great. But when people don't have that kind of access, it can turn tricky. For example, in our community, if someone needs insulin, there is many programs that they can provide, pharmacies pharmaceutics that they can provide the insulin for low cost. But you have to be very careful because when we fill out application, we have to read the really small words, because some of them, they say this is only for US citizens. And if we send application for someone that doesn't have any status, that can be problematic for them in the future, because when they sign the application, practically they are saying that they are US citizen. And in the future, if they want to do with the work with the status, that can be a problematic. That's why we have to be very careful when we fill out those applications, read all the small letters to see what they are saying, if they're safe to apply or not, because some of those programs are specifically for US citizens. In our community, we have many people without a status. We have to be very careful with that. And that's why when someone needs medication like that, we prefer to refer that to a community health clinic that we know that they're going to provide medication to low cost without asking the status to the person.
Thank you so much. We have an important question from Ms. Agaba. It says, hello, I don't think this was already asked, but what advice would you give people who have mistrust on traditional Western medicine due to historical context? She has encountered this in minority communities. What do the team has to say about that?
Yes. I asked Kathy in the chat if you want to respond to that. It's not, it's something that happens also in our PI community. I think in a lot of our minority communities, the trust is huge, I think, as we mentioned. And also in Hawaiian culture, la'au lapa'au is a practice that they use with medicinal chosen people from a specific lineage, like they're called to do this work and they're not licensed practitioners per se. So when we opened up our federally qualified health center in Hawaii, we wanted to offer that as a cultural option for community members. But the thing with that practice is that you can't get paid for it because it is a calling. It is their purpose in our community, in the Hawaiian community, to provide that kind of service or care for community members. So they had to do donations. And if you look at that versus, we're a federally qualified health center, there are a lot of policies that prevent us from providing those kinds of care, especially if we're using federal dollars, because they are not licensed practitioners. So the liability for the health center is huge. But our community members were asking for it because they believe that if they came to see this cultural practitioner who could show their lineage of their understanding of the plants and the medicinal things that have helped us for our history, we wanted to be able to provide that for them. And so they would come in and they would do all the things that our community is used to doing, whether it was for fertility or for like when they had sores in their mouth. There's a certain plant they use to pound and mix, and then they put it in their mouth so that the sores can heal. There are so many things. But we provided a space there to have this conversation with community members about the the options that they have. They can still go to La'au Lapa'au, but they also can see one of our providers and they can share with them some of the best practices and best medicines that they know of that may be able to help them. And giving that option for them was the key thing to get them to come and see a doctor, to trust them. But also the relationship we had built with them also got them in the door because they knew I wouldn't ever refer them to somebody who wouldn't have their best interest at heart and wouldn't take care of them. So because of that, they would go and say, well, I got to see Oretta at the next door in the office, and she told me to come and see you and just talk to you about the things that I've been going through and see how you can help. That was so empowering for our community members to be able to receive all this information, decide whether they want to do it or not, and then make the choice. And many of them decided to start coming to see our providers because they did trust them. And so we didn't have to do much after that. But that beginning stage of building that trust with them and allowing them to make that decision for themselves instead of saying, I don't think you should trust that medicine man. He doesn't have a degree and he doesn't know what those plants, and maybe they're making you worse. To say those kinds of things to patients who have believed in this medicine for all of their lives and their grandparents have passed this down to them was really a slap in the face. And many of them decided not to come to see the doctor. And so, again, the training that we get around motivational interviewing and talk story and using some of our cultural knowledge and lived experiences to have these conversations and to build trust with community members has really taken us further in our building trust with them and providers. Anyone else want to add to that?
Building trust is so important, and it's not easy. My community, the African American community, we've been through so much with the medical community. And so trying to teach people how to advocate for themselves, because we don't have a whole lot of physicians in Utah practicing that look like us. And so we have to make do with what we have, and we need to be able to advocate for ourselves and let the people know exactly what we want and how we would like to achieve it with their help. So at Calvary, we started the diabetes prevention program because it's a very trusted place in the valley. You say Calvary Baptist Church and people automatically know. The pastor, they automatically know about it because it's been in Salt Lake Valley for over 130 years. And so people know it, people trust it. So we started the program there for people that would normally not want to engage with the diabetes prevention program. They were intimidated. They didn't feel like they were understood or they had a voice. And so we gave them that voice. And the outcomes, we had people that had their A1C was a 12 when they started, and it came down to 6.5 by the time the program ended because they trusted us enough to do the work, enough to say, you wouldn't lead me astray because I believe you. It goes a long way, the trust.
I will add to what Kathy and Oretta was sharing about the information or misinformation in the media about medication and how sometimes community members have the perception like, oh, the doctor prescribed me this medication because he's going to gain something for prescribing. Maybe I don't need it, but they prescribe it. And that is so hard because sometimes people, when they are diagnosed with prediabetes, they say, no, I don't have prediabetes. Yeah, no, the labs are wrong. The doctor probably is wrong. I need to do the labs again because they want to change the diagnosis. And when they receive like metformin or a medication, they say, why they prescribe me this? Because they're gaining something for this prescription. And I want to know what is the second effects for this, that all distrust in the system is so hard because you have to talk to people and explain what the medication is doing, why they have to take it, what is the benefits and side effects and all that, because of this information in the media about medication and how pharmas works. And yeah, all that I think is creating this gap between the patient and provider. Like, I want to trust you, but at the same time, I don't know if I can trust you. And it is so hard for community members to fill that gap.
I live in Eagle Mountain, and it's a very diverse community here. But just as an example to the medication and the trust around the medication piece, um, everyone talks about the diabetes and, oh yeah, I take metformin, or I was prescribed this, and then they will start comparing, how, oh yeah, this works for me, or no, that doesn't work for me, it makes me whatever, talking about those side effects. And then the conversation will lead to things like vaccinations, like, again, which all are conversations around trust. They're just debating, who they trust about where they get their information from. And vaccinations is a huge topic, which is probably one for a whole different CHW talk. But I just bring that up because the debate or the conversation was around, I heard that this made this person sick, and the other person's like, well, if it wasn't for that, my kids wouldn't have survived because they didn't get vaccinated. There's so much information nowadays. That's the hard thing about these days, is that everyone has access to so much information, but who do you trust and who do you believe about what information is true? And that's why we need to work closely with you all, closely, to just help each other to understand where people's, not just around our ethnic cultures or communities, but around just our different individual cultures and families that we grow up. Our upbringing is sometimes a way different than our ethnic cultural beliefs. And so we want to just explore where are patients at with these topics, with their health, with the medication, with provider relationships. Like, where are they with that? And let's explore that, because we want to make sure that their care plans are developed to improve their health outcomes. Like, to just give someone a care plan out of the EHR that says, like the discharge papers you get, follow the instructions, go home, ice your leg or whatever, take this many Advils, to just give someone that who faces a lot of these barriers or who might not even know how to read, it's ineffective. And we see these kinds of things every day, especially around the chronic diseases that are most prevalent in our communities. And so that piece is so important. Francis put in the chat, Jareen Fall is a wonderful Black midwife that practices in Salt Lake and South Jordan. Yes, and the care, thanks for sharing the Care Fair resource. Most of us are very engaged in all of the Care Fair kinds of resources out there, because that's where we connect our community members to. If they can't, depending on where they live and what they need, we're able to send them to these great resources where it's a one-stop shop, which is also a best practice for our community, is sending them to places where they can get the vision done and the glucose test done and the blood sugar and all of the things. That is the best practice in the work that we do as well. Kafika, sorry if I pronounced that wrong. Are the La'aula Pa'au still around in centers like you mentioned before? Yes. Actually, in Kahuku or Hau'ula, where I was before, they no longer have it available because of the liability piece. We still do refer to our native practitioners outside or through the Native Hawaiian health systems because they can still offer that, but we don't do it in the health center that we were offering it out of before. Said,
I would like to add something to this best practice is we were talking about diagnosis when when the patient do the labs and it's time to call them and tell them about what happened with the labs. Trauma informed we need to be more sensitive about this diagnosis because usually they call in the phone, they call and said, oh, your labs results are back and it looks like you have diabetes. You never know what the person is doing on the other side of the phone. For us in clinic and people in clinic is normal that you talk about this because you talk all the time with many people about it. But for the person that is receiving the diagnosis is so shocking and so impactful because it's you never know if they are working, if they are driving, what they're doing. Maybe they're going to get distracted because of this and have an accident at work or driving or something like that. Because this diagnosis can be shocking, can be frightening as well. And for some people, it could be devastating. This diagnosis without any sensitivity, when they tell over the phone, it can trigger some fears, anxiety, and a sense of loss too, because all our communities, we have that sense of loss. We lost so many things. And when they receive this this news, it can develop that anxieties, all this emotional response to the traumatic. It could be traumatic because you never know how the person is going to receive it and how it's going to create that emotion inside them. We have to be very sensitive about this. And it's a practice that I know not all the clinics have, but this is something that we advocate for the well-being of the community members to be more sensitive when they receive this kind of news. Is a best care practice, I think. Yeah.
I wanted to ask Kafika, are you able to unmute and share more about that experience you shared in the chat? Maybe not. I can't see anyone else. That's why I don't know if someone's saying yes or no. But I don't know
Kafika
if you all.
answers, she answers, yeah.
Oh, okay.
Hello.
Hi.
Hi. I'm Kavika. But basically,
Oh,
um, apos is basically boiling everything that makes your nose hurt and inhaling it all. So, for example, like things like ginger, lemon, everything like that. But besides that, that's the only thing my mom had ever told me about like medicine, where she's from. And our family's from Chuk. My mom grew up on an island called and there's pretty much like nothing on there. They have like one store.
and you pronounce your name Kavika?
Kavika.
Oh, okay. Sorry.
No, you're fine. It's because my
Yeah.
dad spelled it funny.
Oh,
Uh,
yeah. Thanks for sharing that. I was just reading the end of your thing that said that it's sad that traditional medicine was preserved in that way. I know that many community members want to see more of that offered, but because of the like licensing stuff, they don't offer it out there. And so I know for the Tongan community and the Samoan community, we know who these people are, and so we're like, my grandmother-in-law was a midwife, and she knew all the medicines for fertility. So when people couldn't have babies, they would be at our house all the time. And we're like, why are all those people outside? And my husband was like, well, they came to get fofo, which is massage in Samoan and Tongan.
Uh-huh.
Yeah, and so that she would massage their stomach with some kind of leaves and things that she did, and many of them would get pregnant. And so there's so many practices. I mean, I experienced them personally as a child, and um, we laugh about the whole VIX thing because the Latinos also share that same kind of learning growing up that, oh, if anything's wrong, just to get the VIX, you know?
Uh-huh.
But yeah, I wish that we could do more to share that and also learn more about the families who continue to pass down that practice. But I went to Chuk a couple of years ago to do a community health worker program around diabetes. It was for National Diabetes Prevention Program, and we stayed at a hotel that was also a kind of a bar and grill. People used to go out on a ship on the boats and go out and come back. But it was started by the mother of the owner, who she was a nurse back in the day in Chuk, and she built a home where they do community services out of there. I don't know if you know where that is.
Oh, no, I don't, but that sounds really interesting.
Yeah, it was really interesting. We got to tour the island and visit a lot of the places that the military or Japanese, I want to say, had been and that they started the hospital there. It was really interesting. Sorry to go off track. But again, these best practices have been very informative for a lot of providers who wonder why, well, no wonder when I seen this patient, their belief or the comments that they said around whatever treatment they were getting in the hospital, they now could understand where that came from. And so that's the whole point of us sharing experiences and beliefs from our communities, because your patient populations that you see moving forward are going to look very diverse. It's not the same as even like 5 years ago. And so we really just want to help provide the best care that we can as a team, as a collective, on the community level and on a systems level in these areas where our communities are really having a hard time. So social determinants, because someone remind me again the percentage of physical care versus social care happens in a person's medical experience or when they go to the providers. I forgot what the percentages are. Do you guys remember?
Like
20% medical.
in 80 social mental health.
20% medical. So you can imagine, even if you give them something that's going to work and for their diagnosis or for their chronic illness, when they leave the hospital or the clinic, you can guarantee you're going to see them again because the social pieces are not being taken care of. And that's the piece the gap that we want to fill, because many of our communities or one of the best practices is to refer them to a place that provides more holistic care, because that's how, like the medicine wheel that Ivana brought up, we also have a wheel that healing wheel called a lokahi wheel that we work off of in it, and it's all the things spiritual, physical, mental, all of the areas of health, not just the physical. Anybody have any other questions or comments? And thank you, Kavika, for coming off mute and sharing that with us.
We do have 5 minutes left. So we want to take last 5 minutes to answer any questions. A few of the other slides are Utah models of care for diabetes. And you'll also have these slides available. So if you do see any of the information in the slides later on, you can also feel free to ask us questions, email us, and get in contact with Tati, and we're able to kind of respond back. and also Medicaid population, some of the strengths, and then some of the barriers to that. I know that we weren't able to get through all of the slides, but I also want to leave time for anybody that does have any questions or feedback for us. I feel like it was a great conversation hearing from the other CHWs. I always learn a lot from them and insights from their communities too.
Can we, this slide that Ivana is on right now, these recommendations, we could really use your help in helping us to share this in other conversations you might be in or other presentations you might be in where they're sharing like, we don't know how to do this or this, we have an issue or a barrier with these kinds of patients. The information that we share here with you, we want you to share with others in the field, because the best way for us to even get to a policy and advocacy level to change the policies that are there that are barriers is to create more awareness. And so these recommendations we like to share with all of you, because these are practical ways that you can help us to better take care of the patients that we all see, especially our most vulnerable populations. This is why this program and all of the work our community health workers are doing is really important, because we're a small percentage, but we're a very unhealthy percentage of communities that are not getting the care that they should get, but don't have access and face all of these barriers in receiving that same care. And I know that this is a hot topic across I hope I don't get in trouble for this, but across the nation. But we just want to make sure that there's equity in all that we do, that we're not, it's not to single out a certain population and give more resources to them. It's to make sure that we're all getting the same access to these resources, and that we understand moving forward, we want to look at the best way to better serve our community members, especially the ones that are getting the most sick and who are suffering more than they should. Because I tell my community every day, do you know you don't have to die from diabetes? Like, it's a preventable disease. My community and my family will tell me, well, I want to eat whatever I want and be happy now, and then at least I'll die happy. And I'm like, really? That whole mindset is what guides everything we do, because it's not a matter of if we're going to get diabetes, it's a matter of when. And that's the perspective a lot of them have. And so we want to make sure that they understand you don't have to die from diabetes. Like, we can prevent these deaths, and you can live a longer life if you just make a little change. But I've talked enough. Uh, Anyone have any questions, comments? We appreciate your comments, because we really don't want to keep giving these CHW talks and everyone's like, oh, it's so boring, or they all say the same thing. We want to know what you want to hear and what you want to know about the communities we serve or represent, and we want to just answer those questions for you.
Thank you so much, Oretta and team. As always, an impactful and powerful presentation. We will post this on our YouTube channel. Please share with your peers how amazing it was and all the advice we got and all the knowledge presented, so they can also watch it. Thank you for filling out the surveys. And I hope you all have a lovely evening. We will see you for another CHW talk in November. We will post this. Thank you to our wonderful team. Big round of applause for them. Yes, magnificent and wonderful, and so proud of all of you. Have a lovely afternoon, and thank you for keeping it real, CHWs. We really appreciate that. Thank you.
Thank you.